I've got the privilege of working with you today in terms of introducing the work that's happening in aged care, predominantly in residential aged care. So I'm really encouraged to see the work that's emerging and that we can do this today, sharing some of the examples of what people have been doing in residential aged care. So the first presentation is Residential Aged Care, update on the latest research and best practice. So Professor Stephen Lord and Jasmine Menand. And Jasmine, I think you're the person that's going to be speaking to this today. So we welcome you.
So good afternoon, everyone, and thank you for joining this session. I'm Jasmine Menand, and today I'm going to present to you an update, a very brief update on the best practice falls prevention guidelines that we've been working on together as a team with Dr. Susan Dyer, who is in Adelaide, Professor Stephen Lord, and Professor Kathy Sherrington, and a whole lot more people who are acknowledged in the final slide. So how this came about, it has been commissioned by the Australian Commission on Safety and Quality in Healthcare, and it followed up from the findings from the Royal Commission in Aged Care Quality and Safety, that there was much room for improvement in terms of falls prevention and mobility improvement. And so we drew together a panel of experts from the Australia-New Zealand Falls Prevention Society, and we developed the guidelines based on several sources. So we conducted some literature review searches for the fall risk factors aspects of the guidelines. We also conducted an update of the Cameron-Cochrane review from 2018, and this update was done by Dr. Sue Dyer and her team, and I'm mostly going to talk about the recommendations that came from this systematic review now. But we also conducted some consultations, some roundtables with clinicians, researchers, and people who work on the field. So just now, in the next few minutes, I'm just going to present to you what came out as recommendations that will be published in the guidelines that will be launched in November at the ANZ Falls Prevention Conference. And I've made it quite simple, taking again the gold bar evidence scales that Stephen Lord has been using over the past few years. And a recommendation with 3 gold bars has a strong recommendation and a high quality of evidence, so based on systematic review evidence. 2 gold bars is still a strong recommendation, but intermediate quality of evidence, meaning there's more work that needs to be done to keep confirming this evidence. There's been randomized control trial to show the evidence, though. And 1 gold bar is high quality of evidence, so systematic review evidence, but conditional recommendation. And you'll see why it's the last recommendation on the last slide. So the first 2 recommendations are that we need to do multifactorial fall prevention, and it should be routine care for all residents. And they should include some educational engagement of staff. And they should be based on individualized fall risk assessment. And here I have put, it's one of the only forest plots I've got in the presentation, and you don't need to read the details. What's important to see is anything, the big bold diamond to the left of the vertical lines means it's in favor of multifactorial intervention. And what these studies are randomized control trials that have included an education component. And the overall pooled result is that they lead to a 36 reduction in falls rate. So this is what to remember, that multifactorial interventions, including education, lead to a significant reduction in falls rate, hence this recommendation. And one big trial that has influenced that pool of data is a trial done in the UK by Pip Logan based on the Guide to Action into Home, which included education of residential aged care facility staff. Next on, exercise, and we've already heard plenty on it this morning, but we know that tailored supervised exercise is effective for reducing falls in residential aged care. And one of the big trials is obviously from Jenny Hewitt, who is here with us this afternoon. And another big thing to consider is that continuation of exercise is required to be continuing to prevent falls. And this comes from this data here. So again, some forest plots. All you need to see is this big ball diamond. When it's on the left of the vertical bar, it favors exercise. If it's in the middle, like here, there's no difference. And what we can see is when we pull the randomized control trials, where the fall rate has been analyzed at the end of the intervention period, we see a clear effect, 32% reduction in falls rate. But if we then look post-intervention follow-up, like several months later, now there's no more difference in the falls rate between people who received the intervention and people who didn't receive the intervention, who were in the control group. So that really illustrates this point that we need to continue exercise if we want falls to be prevented. And further to this work, Sue Dyer also looked at which component of the exercise intervention are important, what comes out from these trials, and strength and balance exercises, and this makes sense. Individualized prescription, moderate intensity, and having sufficient funding for the intervention. And that's what discriminates these studies. So these studies that have been effective have had these components included in them. I think it's this one. Yeah. Next recommendation. And it's mostly based on this trial, well, it's solely based on this trial, which is supplementation of calcium and protein via diet. And it's based on this big randomized control trial that was done in Australia in 60 residential aged care facilities that were a part of this trial, and providing residents in the intervention with additional milk, yogurt, and cheese led to 33% reduction in all fractures and 11% reduction in risk of fall. So it's really significant. It's a big advancement, and this obviously wasn't in the previous 2009 recommendation. So it's definitely a new recommendation based on this trial. And finally, this is unchanged from the Commons review, and that daily or weekly vitamin D should be administered for all residents for falls prevention. This one I circled in red because we should not use high monthly doses or once yearly mega doses of vitamin D. They do the opposite. They have been shown to increase the risk of falls, and this is based on systematic review. And in terms of fracture prevention, residents with diagnosed osteoporosis or a history of low trauma fractures should be prescribed with bone protective treatments unless contraindicated. And the last one, which I mentioned earlier because there's only one gold bar, there's evidence for hip protectors to prevent fractures in residential aged care settings. However, the evidence is conditional because if we don't put them on, we won't get the reduction in fractures. So it's based on that, the one single gold bar. Otherwise, the evidence is there. If we put them on, they reduce fractures. So that's just, that's the end of my talk. I'd like to acknowledge all the people who've been involved in this update of the guidelines. And yeah, watch this space as they will be launched in next November. Thank you.
Thanks, Jasmine. I think in the interests of time, we'll move on. But we are looking forward to these guidelines being produced so that we can actually start sharing them within the sectors in which we're working, and particularly in residential aged care. I'd now like to invite Jenny Griffiths. And I'm delighted to see Jenny. I haven't said hello to Jenny yet, but I've been out to Nyngan, where Jenny is the Health Service Manager of Nyngan Health Service in Western New South Wales. Is Ash coming up with you? Ash is not coming. Ash is over there. Ash is the Falls Coordinator and Management Coordinator for the Far West and Western New South Wales LHT. And Jenny's going to talk to us today about virtual physiotherapy services with allied health assistance support for isolated rural sites. Thanks, Jenny.
Thanks, Lorraine. It's great to be here today. And I just wanted to acknowledge Ash over there, who is our falls coordinator, who provides lots of advice for us, because we have lots of falls, unfortunately. I just wanted to acknowledge today Ash and I have travelled from, Ash has come from Wiradjuri and I've come from Wongabong country to be with you today. And we'd like to acknowledge the traditional custodians of the land on which we're meeting, the Gadigal people of the Eora Nation. We'd like to pay our respects to elders past, present and emerging, and to celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the land and waters of New South Wales. And we'd also like to acknowledge and pay our respects to any Aboriginal or Torres Strait people joining us today. So I'm from Western New South Wales Local Health District. That's us, the big blue bob in the middle of the state. Our local health district services just under 300,000 people. It covers an area of 247 square kilometres, which is about the size of England. We have 25 multi-purpose facilities, and for those of you who don't know what they are, they're small facilities in rural towns that provide a mixture of acute, community and residential aged care services. Western New South Wales has 421 residential aged care beds. Falls in our MPSs continue to be our highest reported incident, and they're nearly double of any other reported incident. There are challenges of being rural and remote, which I can imagine you would all understand. A lot of this revolves around access to allied health assessments and multidisciplinary teams, which we know is so important in managing falls risks, mobility and frailty. We have very limited access to allied health services. So in response to this, our local health district created a virtual allied health service, or a VARS service. So this includes physio, speech, dietetics, pharmacy and social work. This service provides support for sites with very limited or no allied health face-to-face services. So just a little bit about Nyngan. We're a small rural community located on the banks of the Bogan River in the centre of New South Wales. It's an agricultural mining town, and 16% of the population identify as Aboriginal. Nyngan is part of Australia's fascination with big things, and we have a big bogan. If you're ever visiting, stop in and get your picture taken. Our MPS has 42 beds. We have 36 residential aged care beds, 6 acute beds, an ED and a community health service. The only on-site allied health we have is 8 hours a week of physio, who has just returned from maternity leave yesterday. So we've had 12 months with nothing. We've had 48 falls in the last 12 months. We've had 3 harm score 2 falls. We know from our incident data that 50% of our falls occur at the bedside, and 50% of those occurred with residents or patients mobilising. We also know that falls are multifactorial, and there are many things to consider: individual factors, environment, frailty, medications and cognition, to name a few. We're really good at screening people. We do that all the time. But we know all our residents are at risk of falling. Our management plans are very much nurse-driven, with limited or no allied health interventions. This would usually include lots of falls alarms, chair alarms, bed alarms, so lots of white noise for nurses, increased rounding, toileting plans, and reminders for residents to use call bells and walkers, even though they have documented cognitive impairments. So we've become very high-end users of the multidisciplinary virtual services for our residents and patients. So I just wanted to share with you, there's no evidence here, it's just what we can see. So I just wanted to share with you Barry's story. So we've had recent success with the hybrid model where the VARS service was fully staffed and was able to offer some of us face-to-face visits. So we had the virtual physio travel out and do 2 days. So Molly came from Orange and did 2 days. She saw all 25 of our residents and completed comprehensive reviews. Previous to this, our activities officer, Dee, had been running some passive seated exercise groups to keep our residents moving. Molly was able to provide Dee with exercises targeting strength and balance. Molly provided Dee with more exercises and innovative ways to get residents moving based on the comprehensive assessment she'd done. This worked beautifully as Dee knew what each resident would work for each resident based on their previous leisure and lifestyle choices. So this is Barry. Barry's 75 and he's a resident in Nyngan. Barry does have a significant falls history. Actually was waiting for a residential bed in our acute setting and had a fall 12 months ago and fractured his femur. He's had another fall since. Barry was reviewed by Molly, who provided a guided clinical plan for Barry, which was implemented locally. Dee was able to follow the plan without having an on-site allied health clinician. Barry decided that he didn't want to participate in any strength or balance groups or individual activities. So we settled on a walking program for him. Barry couldn't manage more than 50 metres with the walker, and he's now able to do our full perimeter walk, which is over 600 metres. And he's also clocked up 200 metres with just his stick and not his walker. Barry reports feeling great, loves that Dee comes to him for the walks as he needs a bit of prodding. He said that if it was left to him, he wouldn't go. Dee was able to identify that Barry loves a little bit of one-on-one attention. So a chat and a walk 4 times a week is a winner for Barry. So Molly and Dee communicate via email, update each other on residents' progress and ongoing plans. So we've ticked a couple of the boxes that Anne spoke about this morning, which were relationships and trust, because we have that at the site level, and an individualised approach, because we weren't going to get Barry to join any group sessions. And there's just some examples of the group strength and balance work that Dee does. It's very innovative, it's very funny, and it changes up quite frequently. It is so important that residents enjoy the activities or they just don't turn up. We've tried to implement a cognitive component as well, so that beach ball has questions on it, so when you catch the ball you have to answer one of the questions, and if the person obviously or the resident can't read them, Dee will ask them a question as well. So it helps spark conversation and reminiscing. Relevant activities are tailored to individual resident needs, and as you can see, there's lots of different things happening in that space. It can be a challenge at times with no fancy gym or exercise equipment, but it is very doable. And where to from here? So Western New South Wales is about to commence a pilot for a new model of care to support multidisciplinary allied health professionals and their interventions with rural and remote facilities. This will allow more residents like Barry to access individualised therapy interventions from skilled allied health clinicians consistently and ensure that that frequent implementation occurs. Thank you very much.
Thanks, Jenny. Always a challenge in our multi-purpose service, and we have a number of those, not only in Western, Murrumbidgee, Southern and Northern New South Wales. So there's quite a few of combined community, acute and residential aged care beds, and we do suffer from staffing shortages, and staffing itself is a challenge in itself. So that's great to see how you've been innovative in just enabling people to be involved and being active. And so we look forward to hearing more in time as the Allied Health Program rolls out virtually as well. So we wish you well in that, and we'll be inviting you back to present on that in time.